Very good morning. Thanks to the chairpersons and thanks to my dear brother Bansi Bhai for inviting me all the way from Bangalore to talk about this wonderful topic of de-prescription in elderly diabetic patients. Um, as a disclaimer, when I was being trained, I was trained by one professor who used to probably give medications for every symptom that the patient explained during the rounds. I had some distaste, he will give some medicines. I had passing gas, he will give some medicines. I'm not passing gas, he'll give medicines. So I had one professor like that. Then I had another professor who said he listened to all the symptoms that are there. And then afterwards he said, this is probably one medicine that will take care of all your symptoms that is there. So that's the background that I'm going to talk to you about in the next few minutes on what we're going to talk about de-prescription. Now, this is the agenda that I'm going to have. We'll talk a little bit about an introduction. Then we'll talk about the clinical considerations and the de-prescription process. Then we'll talk about certain case studies and practical applications. Then we'll understand what are the barriers to put this into practice in our day-to-day practice and what are the challenges that are there. And then we'll try and see if we have some kind of a conclusions on future directions on how we need to proceed regarding this concept of de-prescription. Probably when I talk about de-prescription, I may be sending out wrong signals among the patient that I don't like medicines. No, it is just the process on how we are going to use these medicines in an effective manner. So de-prescription is a planned and supervised process of reducing or stopping medications that may no longer benefit the patients. The goal is to improve health outcomes and minimize the risks associated with polypharmacy. It focuses on patient-centric medical care and optimizing the medications use that is there. Now, why does de-prescription matter in diabetes practice? All of us are aware that elderly diabetic patients are more prone to develop complications, more prone to develop hypoglycemias, more prone as a result of polypharmacy. They tend to have an increased likelihood of adverse drug events. These are the people who always have complications as a result of multiple medications. And that's what we need to identify and make sure that we reduce this concept. Now, globally, what's happening is diabetic patients are increasing their average lifespan. For this, when you talk about elderly, we are cutting off a figure of 65 years. And 20% worldwide belong to this age group of more than 65 years. Now, this aging population faced complex health issues due to multimorbidity and polypharmacy. The emphasis should be on personalized care and improving patient outcomes. We all know that these diabetic patients are more prone to hypoglycemia. They're more prone for cardiovascular complications because of the risk for developing cognitive declines, increased falls. They tend to have multiple organ complications, including renal complications. Now, what's polypharmacy? Polypharmacy is associated with poor medication, poor adherence, adverse drug reactions, and increased hospitalization risk. It reduces the quality of life. It complicates chronic disease management. It also plays a very important reason on why we should start de-prescribing as a very important part of our clinical practice. Now, by definition, de-prescription is a systematic approach to discontinuation of medicines that are no longer necessary or it may be potentially harmful. The goal is to improve patient safety and quality of life, to reduce the risk of adverse events, and to align treatment and patient goals and preferences. Now, whenever we talk about de-prescription, it has to be patient-centric. It cannot be a mass treatment. It has to be individualized to the patient who's sitting in front of you. It has to be a shared decision that we need to take along with the patients and the caregivers. We need to individualize the treatment based on their life expectancy, their individual health goals, and their individual preferences. It enhances patient engagement and adherence to safe medication practices. Now, let's move on to what are the considerations that we need to have related to this concept of de-prescription. Now, when is it called polypharmacy? When a person is on concurrent use of 5 or more medications, we call this as polypharmacy. it is common in elderly diabetic patients to have multiple chronic conditions. This increases the risk for drug interactions, adverse events, and hospitalizations. Now, what are these high-risk medications that we are worried about in elderly diabetic patients? Obviously, it is the sulfonylureas because of the risk of hypoglycemias, also the insulins. Then we have the NSAIDs. These patients, we know that they are more prone to aches and pains, and there is abuse of NSAIDs, which results in increase in cardiovascular risks. Then they have a whole lot of insomnia. They may be put on benzodiazepines, and we know the effect of benzodiazepines resulting in poor cognition and repeated falls. Then we have our favorite molecule, the glitazones. As the age progresses, these patients on prolonged use, because of their weight gain, also cause bone loss and resulting in bone fractures. Now, after having understood this, there is a described framework on how we should probably go about doing this de-prescription. What is the first step? Conduct a comprehensive medication review. Second step, identify medications with questionable benefits of high risk. Third step, gradually taper to discontinue medications. And the fourth step is to regularly monitor and follow up to assess the outcomes of this de-prescription. Now, there is something called a stop-start criteria. I'll come to this. The full form of the stop-start criteria. STOP is a screening tool of older patients' prescription. That's called STOP. START criteria is screening tool to alert for right treatment. That's called START. Now, these are the criteria that are available. I'll tell you where they started from and how they started from. We probably have to use these criteria whenever we talk about de-prescription. We need to stop certain drugs and start certain drugs if it is not being started in these individuals. Thereby, we are able to optimize the therapy in these individuals. Now, coming to how this all started off, there was Dr. Mark Beer from California in the year 1997. In his own clinic, he started this particular criteria called Beer criteria for his nursing home patients on certain utilizing certain drugs which should be used and which shouldn't be used. And that's how it started off. Over a period of time, from the 1991 to 1997, it started becoming practicing in the entire, not just to his nursing home patients, it became applicable to all elderly patients. Then the American Geriatric Society took over the stewardship of this Beer criteria, and then they have been running this stewardship on a regular basis, and then they formulated this Beer criteria. What does it essentially do? It divides the drugs into 5 groups of drugs. The drugs that needs to be used with, the drugs which are classified as inappropriate for use in elderly patients. The second group of drugs is drugs that should be used or used with caution with certain syndromes. Third is drugs which have got certain side effects. Fourth is a group of drugs that needs to be restricted to use because of organ involvement like renal involvement. Now, this was essentially practiced in the entire US. So most of the European countries do not have this US FDA approved drugs. So then they started off this start-stop criteria in European countries, and that's how they started this. And this start-stop criteria has got almost around 114 group of drugs, 80 drugs that needs to be stopped, and 34 drugs that needs to be started. This is a criteria, this is a tool that is available to us. Each one of us can download this as an app and use this for our own individual practices. And that's how this could be beneficial by making sure that we utilize these tools. There are other tools like the MedStopper, which is an app that can be used on making sure that we know which are the drugs that the patient is on, which is right and which is wrong. And I also talked to you about the Beer and Stop criteria and Start criteria. Here, I would like to substitute this collaboration with pharmacists to collaborating with our fellow specialists and super specialists. That's where the importance is. Most of our patients who are sitting here in the audience, it's unusual to get a person who's a pure diabetic patient at the age of 65 and 70. He will invariably have hypertension, he'll have cardiovascular diseases, he will have benign prostatic hypertrophy, he'll have some depression, he'll have some Parkinson's disease, he'll have some peripheral neuropathy, he'll have a whole lot of surgical problems, urological problems. And imagine this person is going and visiting multiple doctors. We as treating physicians are the custodians of prescriptions for our patients. So what happens, how I have got popular amongst my patients is this. They go to all their doctors, all the specialists, and then to validate the prescription, they come to me. And then they say, Doc, only if you ratify the prescription, you will tell me what needs to be taken, what shouldn't be taken. Only then I will probably go ahead and take this. And that's the confidence that we need to inculcate in our patients so that we are able to deliver the right things for the patients. Now, make sure that you involve the patients in the decision making, put it in very simple languages, and encourage the patients to express their concerns that they have. We need to make sure that we document on why I stopped pioglitazone in this particular individual. Why did I change a sulfonylurea from a glycoside to a DPP4 individual in this particular person? Why did I stop insulin in this person? Why did I change a benzodiazepine into another non-sedating drug? Why did I stop an NSAID in this individual? Once this is documented, it is written in the case sheet, and this document needs to be shared with our fellow physicians and fellow colleagues. You may have that this person does not visit you tomorrow, and if he goes and visits another person, make sure that these reasons are substantiated. And once this prescription goes back to the other specialists, it is not a question of ego here that there is a super specialist who started the drug, and here you are an MD physician, you're going to stop the drug and then changing it into another drug. It is only with the intention of what is right for the patient that you are treating. And that's where you will have to use these electronic records in a very effective manner and make sure that this communication between our patients is so good that we are able to pass on these benefits. Now, how do you know that your method of de-prescription is succeeding or not? The first you'll know is by reduction in the number of adverse drug effects. There is an improved patient-reported outcomes. There are fewer hospitalizations related to medication issues, and we are able to monitor progress, and adapt strategies accordingly in these individuals. Now, what are these guidelines that are there? We need to follow evidence-based protocols that are tailored to patient needs. Use these criteria, the BEER criteria, the start-stop criteria. Make a printout of this, put it on your desk, and make sure that you're able to use this. I'll come to the disadvantages and why we are not able to do that. We need to prioritize the safety and monitoring of outcomes. We need to engage patients and caregivers in every step. Now let's understand certain case studies that are there. This is a 78-year-old type 2 diabetic, hypertensive, and chronic pain. The initial medications were 10 prescriptions, including sulfonylureas and benzodiazepines. The intervention was, after understanding a comprehensive medication review was done, this prescription was reduced to 6 drugs, and what resulted was improved cognition and fewer falls. A second simple case study was this another 82-year-old patient with diabetes and mild cognitive impairment. What happened? We reduced sulfonylureas and switched to DPP4, and here we reduced hypoglycemia episodes and thereby stabilized cognitive functions. Now, how do you manage de-prescription in complex cases? I gave you this example, right? A diabetic, hypertensive, cardiovascular disease, osteoarthritis, benign prostatic hypertrophy, peripheral neuritis, some trigeminal neuralgia. You can imagine these complex cases associated with syndromes, obesity, hypothyroidism. When you start writing the prescription, probably you'll start from one page and then turn the page and then write another set of drugs. That's the number of drugs that you will ultimately land up using these number of drugs. But those complex cases is something that we need to be very wary of and make sure that this adjusting of de-prescription is done in a very cognitive manner. We need to monitor them closely and adapt as usual. Now, we need to focus on outcomes, and this focus is on improving functional outcomes and reducing hospitalization risk. The patient-reported outcomes is very vital to measure the success of this de-prescription program. Now, am I talking out of my hat somewhere? No, there are real-world studies that have been done, and the real-world studies have shown that de-prescription reduces hospitalization admissions by almost 25%. There has been significant improvement in the quality of life, and also it's been reported in large-scale studies, cost reduction, reduction in hospitalization, quality of life being improved. There is no reason why each one of us, once we go back to our practice, put a thought to this process of de-prescription into our practice. Now, it also is very important to note that 85% of the patients went back happy, healthier after deprescription. The emphasis is to make sure that you have an open communication, and please make sure that the patient satisfaction is the vital cog in the wheel that you need to focus on. We always have to ensure that this collaboration happens. If I call my nephrologist, I call my neurologist, I call my gastroenterologist and tell them, Doc, this is a prescription that you have given, but this is the reason why I'm feeling that this patient needs to be changed on this drug. Trust me that you and your esteem goes up in front of those fellow specialists. You're not going to be pointed fingers at. And that's what I want each one of you. You need to justify on why you're doing it and explain this to your colleagues, explain this to your specialists and super specialists. And I'm sure that everyone's intention is to do good to the patient, and they will definitely be happy to participate in this process of deprescription. Always ensure that you focus on patient-centered approach and follow the standard protocols that are there. Ensure that the patient is always taken into confidence. The patient's parties are taken into confidence. They have to have a shared decision making in everything that you do, why you do, what you do, and make sure to let them understand what is the risk benefit summaries of doing this. Now you need to do a checklist. Now what we do is we ask them to do, this is called as a brown bag practice. Now every time that the patient comes to you, please ask the patient to get all his drugs in a brown bag. In a bag. Okay, brown is probably a color. That particular bag that you examine is going to be of importance. Now we have the pill organizers. You have those pill organizers where patients cut the tablets and put it on Mondays, Tuesdays, Wednesdays, morning, afternoon, night. You don't have the names out of that. So you will be completely lost.
Can we make faster because there is a call from Bansi sir?
Give me 2 minutes.
Thank you, sir.
I have 3 minutes according to the clock. Okay. This is important for us to make sure that we follow this and make sure that we're able to get people to follow this on a regular basis. Now, to make sure that implementing these prescription programs are successful, we need to develop this as an institutional protocol. We need to train healthcare providers, and we need to monitor and evaluate program success. We need to monitor this on a regular basis and use patient-reported outcomes, and regular reviews will help us to make sure that we have sustained successes. Now, what are the barriers? These barriers could be either patient-oriented or the physician-oriented. Now, let's come to patient-oriented resistance. There is a fear of losing the benefits out of certain drugs. I've been taking this drug all this time. I've been having acidity. So if you take off this proton pump inhibitor, I don't know, I must go back to get acidity. But the acidity is actually drug induced, and they don't know that. And if you stop the drug, you don't require that drug plus another drug to treat acidity. So it is a psychological effect of these particular people. There is an emotional attachment to long-standing medications that they take. So that is what we need to address in these individuals. Some people they kind of become cognitively addicted to those things. And it also depends on different patients. The higher intellectual patient will probably have higher resistance. The lower intellectual and the lower educated people, they have lesser resistance. So that is another thing that you need to take into consideration. Now, what is the physician-oriented problems that we have? A lack of training in deprescribing guidelines. That is the main problem that we have. We need to develop our own guidelines. We need to make sure that there is enough amount of time. Whenever I deal with any of my old patients, my OPD staff knows that I'm going to take 25 minutes to 30 minutes to deal with this particular patient before they can send another patient, because that's the amount of time that I'll have to take to explain to them on each of these drugs. So whenever there is a 60-year-old, 65-year-old, that's the time that I take to make sure that I describe to them about this process. We need to talk to them about enhancing the consultation time to get the benefit for these individuals. Communication plays a very important role, and making sure that sharing these medical records would help us, and make sure that we also incentivize people by putting up this deprescription. A classic example is my mother. She's a CGHS employee. You know all our CGHS medications, how they do? 1 month they will give you one drug, the next month they'll give you another drug, the third month they'll give you another combination drug. And it becomes so very difficult for a person to follow all those drugs. So now she doesn't want to give a drug that I take. She doesn't want to burden me. She wants to say that I have a CGHS beneficiary. I'm getting free drugs. Why do I have to burden you by taking these medications? So it's important for me to make sure that I explain, this is the drug, this is the reason you need to take this. Okay, if they have a combination like this, you need to play a mix and match with these drugs. And that's the kind of an effort that we need to take. And when we do this, I'm sure the benefits will be more to see in our patients. Now, to conclude, these are some of the key takeaways. De-prescription improves patient life and quality of life. It requires collaboration, patient engagement, and evidence-based practice. We need to make sure that we reduce the adverse effects and improve health outcomes by de-prescribing, and thereby lower the health cost and enhance patient satisfaction. What are the future directions that we have? We need to have personalized medicine. We need to have patient-centric approaches. AI is going to play a big role in de-prescription. It will help us identify high-risk medications and predict outcomes, and it will help us pick and choose a kind of drugs that we need to use. We need to expand education and training programs. Conferences like this will help us. Give me just a second. Last few slides, okay? We need to make sure that we are able to complete this process of education, and there should be policies to help us follow this de-prescription. And this building partnerships between primary care specialists and pharmacists is important. This is how we need to do the checklist, perform medication reviews regularly, prioritize high-risk medications, and involve patients in every step. This is the future of de-prescription. Embrace innovation and digital health tools, promote de-prescription, and the call to action is this, the last slide. Healthcare providers should prioritize de-prescription in elderly diabetic patients. The policymakers should support de-prescription initiatives. The patients should be proactive and ask questions about medications. Together, if you're able to do all these things, I'm sure we will be successful in making a healthier and aging population, which is going to be less of cost. The closing thoughts: de-prescription is a proactive approach to improve safety and quality of life. Let's all work together to promote safe medical practices. Thank you. Thank you so much. Thank you.